Well, welcome to today's webinar. My name is Brenda Jagatic, and I'm the Diabetes Education Coordinator at the Indiana State Department of Health under the CDC 1815 grant. My role has been to increase diabetes education in the state, and part of that has been providing technical assistance to programs, organizations interested in delivering their services via telehealth. Now, our first webinar on Friday, Marianne Hodorowitz discussed Medicare reimbursement, and for those who attended or did not attend, her slide deck and the recording of that presentation is now available on the Upper Midwest Telehealth Resource Center website, which is listed right now on Becky's slide. Lovely. And then, of course, today, Becky will be discussing Indiana Medicaid and private payer coverage. And then once I'm having a good understanding of reimbursement, the next step for organizations who are interested in moving forward is really to identify your key stakeholders, your telehealth experts, so that you can start to develop a strategic plan. And I'm currently in the midst of writing a telehealth toolkit for Indiana around diabetes education. And the toolkit's going to look at information for organizations that have patients that they want to refer for diabetes education via telehealth, as well as the organizations that want to deliver their services via telehealth to patients with diabetes. And I also want to make note that Becky and I will be doing a presentation at the Upper Midwest annual conference in July in South Bend in July. But now it's my pleasure to introduce Becky Saunders as our speaker today for our webinar, who will review Indiana Medicaid reimbursement rules and waivers, and also discuss coverage by private payers in Indiana. All yours, Mary. All yours, Becky.
Oh, thanks, Brenda. I just wanted to draw your attention to the slide. Things with the COVID-19 pandemic are changing very rapidly. So please be advised, we provide guidance on billing issues based on our experience, anecdotal information, and through research. Following our advice does not guarantee payment, and we always recommend you check with your payer or your Medicare administrative contractor to verify our information. But I've done my utmost to make sure that everything is up to date. In today's presentation, entered stuff that has just happened in the last couple of days. So I can't not talk about the National Consortium of Telehealth Resource Centers. So you'll see the lilac states here. Indiana is in the middle of the 4 states that we cover. So we, as the Upper Midwest Telehealth Resource Center, we cover Illinois, Indiana, Michigan, and Ohio. But we're part of a much larger consortium, a national consortium of telehealth resource centers. We are all federally funded under HRSA, under the Federal Office of Rural Health Policy and the Office of Advancement for Telehealth. Together, we work collaboratively to do things like put together a website, to bring national webinars once a month, and for many of the administrative back-end things that we do, as far as creating handouts and making sure that our whether you're in New Jersey or California or American Samoa, the answer to a single question is going to be the same across all of the states. Also here on our slide, you see the 2 national resource centers. The National Center for Policy is out of Sacramento, California, and a big shout out to Ray Dizon, who is hosting us on their Zoom license today. And then the other national center is the National Center for Technology, and they are based out of Anchorage, Alaska. And we'll talk more about those 2 centers as we go along today. So here's a screen grab from the national website, telehealthresourcecenter.org. And we've got different resources. There's an interactive map that you can find a different resource center depending on your state, different flyers. Ray has done an awesome job collating all of the different events from the different telehealth resource centers, and they are available on that website as well. So my 30-second elevator speech is, people come up and, well, what do you do for a living? So I've coined the term virtual librarian. A lot of what we do as a telehealth resource center is comb through documents and resources, create our own resources when needed, provide technical assistance, answer questions, and connect people with other programs. I do a lot of presentations and trainings like what we're doing today. We help people assess their projects and figure out the best way to go forward. We lots of getting started guides on our website, ideas to help get the ball rolling within your organization. I always like to start off by talking about the difference between telehealth and telemedicine, and sometimes they're used interchangeably. I try really hard not to. When I use the word telehealth, what I'm really talking about is the overall overarching using data for healthcare purposes. It could be education, it could be using vitals data for remote patient monitoring or chronic care management. And then when I say telemedicine, I'm really talking about that billable encounter between the patient and the provider. And that's really what we're going to focus on today. There are also two types of telemedicine. There's asynchronous telemedicine and synchronous telemedicine. Asynchronous is better for things like dermatology, radiology, anytime you're taking data and collecting it in one place and sending it to another. And synchronous is really a live and interactive exchange of data. And that's really what we're going to focus on today when we talk about billing for telemedicine encounters, even with the COVID waivers that are in place. The last thing I want to mention is that telehealth is not a service in and of itself. We get a lot of questions from folks that are not familiar with telemedicine, haven't really dug into it too much, and they're worried about licensing for telemedicine. There is not a specific license out there to say, I'm an RN and now I'm going to get licensed for telemedicine, or I'm a physician and I'm going to get licensed for telemedicine. It is a skill set. And we're going to talk a little bit towards the end about webside manner instead of bedside manner. So let's go ahead and go forward. I'm going to throw a lot of resources at you, but you will get these slides as a registered person for today's webinar. We'll make sure that you get the recording and the slides. We'll have those posted in a couple of days on our website. But we're really focusing in and digging into Indiana Medicaid reimbursement today. I will mention private payer in a little bit, but what I want to make sure is you understand Indiana Medicaid fee-for-service reimbursement. So if you go to, and I've got the link down here at the bottom of the slide, if you go to the indiana.gov Medicaid page and you go under providers, you're going to see these four things. And we're going to, you're going to see Medicaid Policy Manual, and that's your basic Bible for providers getting paid under Indiana Medicaid. Then you're going to see the provider reference modules, the code tables, and the companion guides. So we're going to spend most of our time today talking about the provider reference modules, because within the huge bubble of Indiana Medicaid reimbursement, we're going to talk specifically about diabetes, self-management training, and telemedicine in conjunction with each other. So those two reference modules, the first one, the Diabetes Self-Management Training Services. This was last updated July 1st of 2018, and it is available on the Indiana Medicaid website. I have put together, and these are just screen grabs, directly out of this guidance. And I'm not going to read everything. You guys are smart people, but I just wanted to point out some different things that appear in that guidance. So, the Indiana Healthcare Coverage Programs, or IHCP, covers DSMT, and there's different activities that are included under that. So it very clearly lists what different types of activities can be included for DSMT, and it tells you how it's covered. In order to get payment reimbursement for that, you have to have, and the medical necessity is sort of being waived right now, because no patients can be seen in person, very rarely right now. And it has to be ordered by a physician or podiatrist and provided by a healthcare professional. So who can deliver that services, or those services? DSMT can be provided by any of the providers listed on this list. Something that Brenda and I have talked a lot about, and Marjorie as well, is, well, shoot, there's not diabetes educators listed on this. And I don't know, Brenda, if you want to speak a little bit about that.
Sorry about that. Yes, what I'd like to say is that one of the challenges with diabetes education programs moving forward to deliver this via telehealth is that a large percentage of educators who deliver this face-to-face are not unable to deliver this via telehealth. And that is that the legislation is saying that dietitians can do this, but nurses are not on the list. Now, you can say that pharmacists are on the list here, which is different from Medicare. Medicare says only RDs as a typical, in terms of a typical diabetes educator. So what we do know is our professional organization is having conversations with Medicare to see if we can have that changed. Because something like around half of all the diabetes educators are nurses. So we're not allowing half of our educators to work. So we have diabetes educators at home that could be delivering services from their home to their patient's home. And when we talk about this, we recently changed our name. We used to be certified diabetes educators. Well, now we're considered certified diabetes care and education specialists. And why I like highlighting that is it's not simply giving people education about how to count carbs, but it's also, for instance, families where, let's say, they had a child who was diagnosed with type 1 diabetes 3 months ago, and they're struggling with frequent highs or they're struggling with frequent lows. This is the work that diabetes educators do, and it's so important to provide those services so we can prevent ER visits or hospitalizations, because the ultimate goal of telehealth and why Medicare is doing this, or CMS is doing this, is so we can help alleviate the burden on our hospital emergency rooms, but at the same time service the needs of people with diabetes in this instance in our communities.
Thank you. So these are the two codes if you're doing diabetes self-management training services that you need to focus on: G0108 and G0109. So that's how you get billed, and these are billed, the U6 designates they're billed every 15 minutes. It is limited to some following circumstances here, and you can request authorization for additional units. What I want to dive into real quickly here is how diabetes and telemedicine can be used in combination with each other, especially under the stay-at-home order that we have right now. So here's the documentation. We always want to make sure that regardless of how, where, when the services are delivered, that they're documented appropriately. So this particular Indiana Medicaid module clearly delineates that information. So now we're going to jump over to the next IHCP provider reference module we're going to talk about today, and this is the telehealth and telemedicine services. So this one was last updated October 1st of 2019. And again, I've just taken screenshots out of these documents. You can certainly go to the website and print them out yourself. It's interesting, different documents are created by different people within Indiana Medicaid, and the diabetes module said these people can deliver these services, and the telemedicine says, well, these people are excluded. So it just a little nitpicky thing that caught my attention. And then what I wanted to point out on this particular page is these code sets here. So the reimbursement under IHCP for telemedicine is limited to services listed in the telemedicine services codes. And if you open the actual document, that code sets links into that. So what does that look like? So here's just, this is the last page of all the different codes. And here I just wanted to bring your notice to that G0108 and G0109 are approved, and they are on this list. You can see that, and we'll talk more about modifiers in a minute, that for telemedicine, all of these codes, Indiana is asking that the 95 modifier be used when billing these on the 1500 form. Again, documentation for telemedicine. We want to maintain that at both the distant and originating site locations. And then basic guidelines apply for telemedicine, chart notes, start and stop times, all of that information. And I also want to talk about consent. In the last couple of months, we've gotten lots and lots of questions about consent. And so here's your consent language. Appropriate consent from the member must be obtained by the originating site, and documentation maintained at both the distant and the originating sites. So, and there are written protocols when the member requires a hands-on visit. So what our advice is for the Upper Midwest Telehealth Resource Center is make sure that you're documenting that. You may be a provider that is on a stay-at-home and you can't get back into the office to get to a paper chart. We have different templates and consent forms available on our website that you can use and make into your own. If you're at a larger organization, you should be able to access that information remotely. But we do want to make sure that you do obtain and track and keep those consent forms. Billing and reimbursement for telemedicine, and I mentioned this on our list of codes. Indiana Medicaid is asking for the modifier of 95. They're also asking for the place of service code of 02. This indicates that the service was delivered via telehealth. And again, it points you to the code sets page on the Indiana Medicaid website. There's another modifier that you can use. It's optional, and that modifier is GT. Note here that if a claim includes the POS 02 or modifier 95, but not both, it will be denied. And this is just a roll-up of all, and all this is pre-COVID. Indiana Medicaid reimburses for live and interactive. They do not reimburse for store and forward telemedicine. We already talked about consent, maintaining that in both originating and distant sites. A couple years ago, I think it was 2017, Indiana did change the rule about actually creating a patient-provider relationship via telemedicine for the very first time. So that is huge, especially right now if a patient comes to you and they're under stay-at-home order and you're under stay-at-home order, but you can still see them and establish that relationship via telemedicine. Diabetes educators are very rarely writing prescriptions, but that can also be done via telemedicine. You're muted, Brenda. Did you want to say something about that?
I just wanted to say that we're having all kinds of questions and comments flying around. They're in the chat box and not in the Q&A. So I'm going to ask people if you can put your questions in the Q&A, because that's where it's going to be documented. And one thing that came up that I'm going to need to, we are going to look at all of these questions. We can't answer all of these during this webinar. We will be collecting all these comments and we will be responding to them and posting answers on your website. But the one thing that I'm a little bit confused, but maybe this is good news that I'm not aware of, but it's stating that as a list of providers that can deliver diabetes education via telehealth includes nurses, pharmacists, and dietitians. So I'm not sure if that's new information, but we'll get back and address all of the comments that people have put in the chat box. But please, moving forward, please put all of your comments, questions in the Q&A, because it makes it much easier for us to document and then to respond to everyone.
Yeah, nurses is on this list, Brenda. And this is from the 2018, July 1st, 2018 version of the DSMT IHCP guide. So it does have physicians, nurses, pharmacists, some things that you wouldn't really think about, and dietitians. So nurses is on this list. Okay, we were, okay, here. Okay, I want to talk a little bit about parity in the state of Indiana. We've had parity for telemedicine for several years, I think 2014, 2015. And so what that says is that if and I'll pick on Anthem because they're one of the biggest providers in the state of Indiana. If Anthem covers a service in person, then they have to cover it via telemedicine. And also right now with the waivers for COVID-19, everything just about. Some things don't lend themselves to telemedicine, but things that do lend themselves to telemedicine are being covered under private insurance as well. Some new things that came out this year under IHCP, and this was effective the 1st of this year. And this is new services for fee-for-service Indiana Medicaid. And that was speech language communication, speech fluency, and behavioral and qualitative analysis. And there's the link for that particular bulletin. Unless there's specific questions today about RHCs and FQHCs, I'm not going to spend a lot of time on this. This is kind of a subset of reimbursement, and it's a little bit different. I've got a couple of slides on it. But the big thing for those that provide services or work at an RHC or an FQHC to understand is that Indiana Medicaid already allowed RHCs and FQHCs to both be the originating site and the distance site. And I've been using those words. The originating site is either where the patient is at, or it's the clinical facility where the patient's at, sometimes called the patient site, the originating site. Sometimes it's called the rural site or the spoke site. And then the hub site is the provider site or the urban site sometimes. So Indiana Medicaid allowed FQHCs and RHCs to be either. Medicare, however, only just started allowing FQHCs and RHCs to be the distant site as of March 27th of this year during this particular COVID pandemic. There is additional information on the UMTRC website, and also CCHP is our National Policy Center. There's information on their site as well. Back in that telemedicine provider reference module, there's some specific language about FQHCs and RHCs, and you'll note here there's a hyperlink. So FQHCs and RHCs have their own provider reference module. I did take out the information from the telemedicine reference module enough to see about this encounter code T1015. You want to build that. POS code 11 is an office, if the service is delivered in an office. With telemedicine, again, you want to use the 95 and the POS code 02. And again, it directs you to that code set. So this is if the FQHC or the RHC is the distance site or the provider site. If the FQHC or RHC is the originating site, then again, you're going to use that encounter T1015 and with the appropriate place of service code. The HCPCS code, so as an originating site, you're going to use the HCPCS code 3014, and that gets billed, again, POS 02, signifying that it was delivered via telehealth, and the modifier 95. All right, let's talk about COVID. So I've been talking about all kinds of things, and these were already in place, and now here comes the COVID pandemic. So on the Upper Midwest Telehealth Resource Center website, we have a new resource page specifically for COVID-19 resources. Our screen grab doesn't show it, but underneath this, there is a specific section for each of the 4 states that we cover within the Upper Midwest Telehealth Resource Center. And we've tried to do our best to include bulletins from the specific Medicaid programs for those states, and also executive orders with waivers for many things that have been waived during this particular pandemic. One of the biggest things that I want to talk about that has been waived during the pandemic is HIPAA rules. So they've been relaxed. This doesn't mean go out and do whatever you want. It means that if you use a platform for synchronous audio-visual communication with your patient that is not HIPAA compliant, such as FaceTime, Google Hangouts, Skype, Facebook Messenger video chat, those things are not HIPAA compliant, but during this waiver time, if that's the best that you can do to get audio and visual between you and the patient, then it's okay, and you're not going to have to fear retribution for having a conversation, a session with your patient that is not HIPAA compliant. But you still can't use text or email. You can, in the state of Indiana, for Indiana Medicaid, have a telephonic, so that a phone conversation, recognizing that there are individuals that are not good with technology, that only have a telephone, that don't have a smartphone or a tablet or a computer to do an audio-visual conversation. And that information is detailed in the IHCP Bulletin 2020-22 that came out on March 19th. And there was a bulletin also that came out just this past Friday that listed a whole bunch of FAQs. And because we get so many questions, I'm going to come back to this for just a minute, and I'm going to read from this about audio-only communications. So I apologize for not looking at the camera. Any IHCP covered service, aside from the exclusions listed in Bulletin 2020-22 and speech, occupational, and physical therapies, can be provided through audio only, given that the service can reasonably be provided through audio only communication. Some services may be better provided through video. However, the IHCP acknowledges some patients may not have access to video communications, and this is what I was just describing. And it talks about Executive Order from the Governor 2020-13 that excludes speech, occupational, and physical therapies from audio-only telecommunications or telemedicine. So up here, you can see the link to the Executive Order from Governor Holcomb, and that also did come out on March 19th, Executive Order 20-05. So you may be thinking, Indiana Executive Orders, Indiana Health Coverage Program Bulletin, IHCP, what are you talking about? So here are the links, and you can get email updates for either of these things. I encourage you to, and you know, it's interesting. I was thinking today as I was documenting all of this stuff and finishing up my slides, doing this and billing for telemedicine and combing through rules and regulations is a bit like being a detective. You really have to be resolute, and you really have to stick with it to dig through the links and find the information you're looking for. But signing up for things like this to get these bulletins automatically delivered to your inbox, it really does help. So I talked a little bit already about the bulletin that came out on the 19th of March. It did talk about appropriate consent. We've already talked about that. It talked about documentation that must be maintained, and we talked about that. What we didn't talk about yet was that the provider and or the patient can be at home during these services. So we are at a stay-at-home order under Governor Holcomb through April 20th at this point, and that came out yesterday. So I do want to talk about what's different about seeing a patient from home, different concerns about privacy, a website manner and video etiquette, consent, and vital signs. We've really covered consent already. Video etiquette, if you'll see the background behind me, I'm in my home office. It's a normal home office. I'll just leave it at that. My kids are home from school. We're doing e-learning. There are other people in my house right now, but I've told them to, hey, be quiet. My door's closed, my door's locked. They're not gonna come bother us. My puppy dogs are not in the room with me. They are locked in their crates and they're gonna be quiet. I have done some specific things. I do have a window over here. I've got just a little bit of light coming, but I've closed my blinds. I've got a special light up here that brings daylight. I don't have my normal overhead light, which a very yellow halo effect would come on if I did that. So I've done things to try to improve the video, the way that I look. I'm dressed professionally, all of those things. So that covers privacy, that covers video etiquette. We've talked about consent. Vital signs, this is really not pertinent to you guys as diabetes educators, but I'm going to leave it. I left it in here during these unprecedented times. I mean, it's like, you know, we're kind of flying the plane while we're building it kind of thing. It's okay if patients give you their vital signs. If they've got a blood pressure cuff at home, or a pulse oximeter, or they have a fitness band that they wear, that's okay. In your documentation, I would just say, you know, patient took their own temperature and it was somehow document that. Website manner. So it's going to be a little bit different when you connect with a patient over video. When I give presentations over video, I really try to focus. So I've got two screens. My little thumbnail of my video is over here, and I'm trying really hard not to look at that, and I'm trying to focus on the little eye of my webcam because I'm trying to connect with you, my virtual audience or my virtual patient, and that's important. When we do full-blown trainings, if you happen to come to our UMTRC conference in July in South Bend, we'll have some of that going on where you can actually practice what that looks like and what that feels like. As diabetes educators, I have a type 1 daughter who's 14, and as diabetes educators, I know sometimes you talk about food portions. And so you might have pieces of fake fruit or fake food and a plate divided into certain portions. If you are delivering diabetes education training with a patient that is at another clinical location, it's pretty easy to make sure that they have the handouts that you would have in your normal office when you see people in person. When the patient is at home, and even if you were at home, you might not have those things. So you might refer to, you know, common things someone might have around their house, like a fist or a deck of cards, those types of things to relate to the things that they might have available to them. All right, so let's move on. And I've been talking a lot about originating sites and distant sites, all of that. So this is what that looks like. This is how a normal telemedicine visit gets paid, because normally the patient is in a clinical location, being that originating site where you would bill this facility fee, Q3014. However, that's not happening right now. Patients are being told to stay at home. So all that is going to be billed from these telemedicine visits is the Part B professional form. We've already talked about those CPT codes and those modifiers. So that is billing for telemedicine Medicaid right now. I'm going to speed through the rest of this because I want to make sure we save a lot of time for Q&A. I know those questions are coming through. But if you have never delivered DSMT via telemedicine or never really dug into telemedicine, these next set of slides is for you. I mentioned at the beginning, the National Technology Center, they have some great videos and toolkits on their website. You can go there for more information. And if you click on that link from the previous slide, this is what you see. You probably want to look mostly at the Clinician's Guide to Video Platforms, because as diabetes educators, you're really not too worried with blood pressure and electronic stethoscopes and heart and lung sounds, those types of things. You really don't need to worry about that. There is a special section dedicated to home telehealth as well. And then I've gotten the question from folks in larger organizations that haven't really dug into telemedicine about how it integrates with their electronic medical record. So you might be an Epic shop or a Cerner shop or a Meditech shop, or you might be only using Cisco products or Microsoft products. There's a variety of different platforms out there. I'm positive that Epic has its own video module built into its electronic medical record, its EHR system. The others, I'm not so sure. I'm not up to date on that information, but especially if you're from a larger organization, check with your IT departments, your management, HR, and see what's available to you. There may be products that are already in use by your organization that you can quickly adopt for telemedicine purposes. Normally I talk about a telemedicine room design via a clinical setting, and we can talk about lighting, acoustics, wall color, all of these types of things. In the pandemic that we're experiencing right now, all of this is not quite as important, but if you want to do this long term, these are things to think about. I've talked about what I've done here as far as lighting, that type of thing. And I just want to show you a sample work plan. If this is something that you're jumping into now, just for the interim, but you have plans to continue it, then you really want, as an organization, to have a work plan and involve everyone from different groups around your organization and develop some goals and strategies. And you always want to make sure that they're SMART goals and objectives. So specific, measurable, achievable, relevant, and timely. I made fun of myself here and I took some really bad pictures. Here I am looking down in the middle, not paying attention to my webcam. Some inappropriate clothing, see my ugly background here, some bad lighting. Don't do these things. You want to make sure that you have a clean and uncluttered view between you and your webcam so that the patient can see that. I mentioned we have some getting started guides on our website. There's all kinds of things out there to help you get started. And then I've got some standard questions that I like to answer, but I think instead of using the remaining time to go through these, because you'll get the slides, let's go ahead and open it up for Q&A.
Okay.
Oh, go ahead, Brenda.
No, go ahead. Go ahead. No, go ahead, Marjorie. I'll let you do it. Go ahead.
Becky, thank you. This is Marjorie. There was one comment and one question. The first question is not sure what telemedicine means in terms of G0108 for Indiana Medicaid. Is it telehealth?
It's telemedicine. So Indiana Medicaid uses telehealth to refer to care, virtual care for home health agencies, and telemedicine for billing with the clinical 0108 and 0109 codes that we talked about.
Okay, thank you. And then the comment is, as a resource, Kareo, K-A-R-E-O, is a cloud-based EHR that works with small clinics, hospitals, and includes billing, marketing, and a HIPAA compliant telemed portal. We've used them for years, very happy with them. And I just have the person's name, but I don't know the system in which.
Okay. Thank you for that information.
Okay.
Other questions, comments? There's one about a hospital billing the G codes on the UB04. I am not positive off the top of my head. Brenda, can you answer that one?
I seem to have, okay, I'm off of, can you hear me?
Yeah.
Okay, I know that there were questions related to the UB04, and that some hospitals, in terms of, what happens basically is that Medicare allows billing for organizations using the CMS 1500 or the UB04, but Medicaid does not allow for hospitals to use both, which serves as a deterrent in terms of being able to reimburse for services for Medicaid. And I think that was the question. I'm not sure if we have anyone from Medicaid, Indiana Medicaid, who's on this, is a participant who might be able to share with us via Q&A. But I mean, that's definitely something that I think is really important for hospitals that are wanting to bill. Because one of the, yes.
I would
go ahead.
Obviously, my email's on this slide right now, so I would encourage you, go ahead and ask me that question via email about the UB04, and I'll dig into it. I just don't know off the top of my head.
Yeah, and I would encourage everyone who's participating in this, is that if you have any questions related to Medicare coverage, Medicare delivery of diabetes education, Medicaid, Indiana Medicaid coverage of diabetes, DSMT, and questions around delivery via telehealth, please add your questions onto the Q&A, and we will address those. And what we will do is we'll compile a document that lists both the questions and the answers, and it'll be available on the Upper Midwest website for you to review. And of course, the other thing that we can ask you to do is once the webinar is finished, if you have additional questions, you can also send an email to the Indiana State Department of Health website, and that is, it's diabetes heart, with no space in between, diabetesheart.isdh.in.gov. And we rely on you to let us know what it is that are your concerns. And the nice thing is, if you can list those now on this particular Q&A box, we have it documented, and so that we can then take those and answer them for you as soon as we're able to. And then, was there anything else that you wanted to review, Becky, or common questions?
I see a question regarding consent. I do want to address this. For new clients who have not already signed a consent, how do we do this? Is it all verbal and documented? So right now, I would say yes. If that's the best that you can do, make sure you do verbal consent and you document it. What I would imagine right now, if a patient comes to you, and it's going to be a phone conversation that is then going to be set up as a virtual audio, video, or even it's a phone conversation, that's all you can do with that patient, is make sure that you have that documented and save that. You know, if you're dealing with someone who works with computers all the time, and you can send them an email with a document for them to sign and, you know, scan back to you, that's awesome. just do the best that you can under these difficult circumstances.
Yes. And I also see that Hannah has any advice on advocacy for pharmacists under the Medicare spectrum. And I think that under the Medicare spectrum, both for pharmacists and nurses, our professional organization is having conversations, and we're really hoping that we're going to be able to move forward. And then I think the challenge sometimes comes for, as Connie has listed in terms of working as an RD at an independent pharmacy, clarifying whether Medicaid covers dietitians or RDs that are in a pharmacy delivering DSME, because if they already are reimbursed by Medicaid for delivering these services face-to-face, then are they also covered? So that's another area that we'll check with our colleagues at Medicaid. You have more connections than me, and we can see about how we can answer that.
Yeah, and then there's one here about a registered dietitian working at an independent pharmacy. So the list says nurses. Doesn't say registered dietitians, but it did say dietitian.
It did say dietitian, so yeah, we're good.
Dietitian.
Yeah.
So yes, then you could provide services DSMT from home or from the pharmacy. I don't know that pharmacy is an eligible originating site, but right now it's waived, and you could be at home. There is a HIPAA compliant version of Zoom. There are also, as a federally funded program, we can't make recommendations. We can provide you information to make your own educated decisions. So I would encourage you to go to the technology website and look at all the different video conferencing platforms that are out there.
So Becky, I have a question. I have a question for you. If there's an organization that is going to be delivering or is currently in the process of delivering telehealth services, and it's towards Medicaid beneficiaries, are they able to reach out to you for an individual consult? And how does that work?
Normally, yes. And I provide my email and not my phone number. I don't answer my phone these days. I will say that we call these technical assistance calls.
Okay.
We have done more technical assistance in the month of March than the previous 6 months.
Okay.
So if you go on our website, I highly encourage you to look at our events. We've got a multitude of events, and I've tried to pick out lots of different things. Like we're going to spend one day just talking about consent forms for half an hour. Email is the best way to get a hold of us. And we're wading through a lot of questions, so please be patient with us.
Yeah, okay. Because I think that the traditional Medicaid, I don't think we discussed this with regard to consents, is that traditionally before the pandemic waivers that came around, that if you were offering someone a Medicaid beneficiary in Indiana telehealth, they had to have sign a consent, or you had to at least give them the option of both in person or, yes. And so that still needs to be documented, I'm assuming.
Yes.
Yeah. True. But I think what I would like to do at this point is maybe I'm hoping that maybe people will still feel free. We still have lots of participants who are listening. If you want to go ahead and still put in some questions and answers, but at this point, I'm just going to do a little bit of end of webinar housekeeping, and then we can still answer questions as we're continuing. And that is, I would really like to thank the Upper Midwest Telehealth Resources for helping to coordinate these series of webinars. And I'd also particularly like to thank Becky for her collaboration, both in previous face-to-face TA we've provided for hospitals, but also for her help in planning these webinars and today's presentation. I'd also like to thank Autumn for all the technical assistance that she provided, and our gentleman from the National Consortium, is it Ray? Mm-hmm. I would like to thank Ray. Also, what I would like to let people know is we are having another webinar on Thursday. Thursday's webinar, our speaker is going to be Tony Song. Tony is in California. So he's going to share his story And granted, it's a different state, and we know every state has different state laws, but I think we can still learn from him. His company has been delivering diabetes self-managed education for 8 years. And he is now offering diabetes education self-management services into the homes of people with diabetes. And so he is going to share his experience in terms of starting a program, hurdles that he's identified, barriers, and how he's able to overcome those and to become very successful in the delivery of telehealth services. So I think he shows a picture to us of what the future could be. And so I encourage everyone to think about registering, and you would register for Tony's webinar, the same place that you've registered for today's. The other thing I want to give you a heads up is Tony had some questions. He wanted to know a little bit about our participants and about who would be attending his webinar. So he had 3 questions that we're going to try and help him get an answer to. And that is, we are in the process of putting together a very short, a very brief survey monkey. And with that survey monkey are 3 questions we're asking you to just give us information where you are in your journey, what are your barriers, what are your concerns, and that will help us and probably for you, help yourself in terms of figuring out like, what is it we need to be working on, but also it gives us direction to the content for Thursday's webinar, because we're hoping, as we have with all of these, we're really trying to make sure we're focusing on what your needs are, your questions are. So you will be getting an additional email with the link to that survey monkey, and if you can complete it, we would really appreciate it, because we want to give you the best possible information in our webinar. So I don't know, let's see if, Marjorie, are there any more questions?
I just wanted to make a comment that my connection was in and out, so if you already answered this, but there was one question, and we could even provide DSMT by telephone. And my understanding is that at this time, it needs to be video and audio in order to bill. It needs to be 2-way in real time. So a telephone only would not be a billable service.
Well, but there is a waiver for telephone only right now.
Okay, thank you. Then I missed that.
So yeah, if you go back to the different bulletins that have come out from IHCP, the first one came out March 19th. It does allow audio only, but it cautions us, you know, some things are not good for audio only. Sometimes you need to, you know, if you're a dermatologist, having a conversation about a rash is not a good idea. You need to see the rash. But if that's the best that you can do to meet your patient's needs right now during the stay-at-home order, then that's what you have to do. Okay, thank you, Becky. And then the second thing that I wasn't sure was clarified, can a hospital bill those G codes on a UB04, or RDs are not credentialed individually with Medicare and Medicaid? And my understanding is that whatever you are doing now, whatever form you are using now, either the 1500 form, you would still bill on that, but you would use the 95 modifier indicating that is telehealth. And also, if you're using the UB04 form now to bill, you would continue to use the UB04 form, and you would use the modifier 95 indicating it's telehealth. Okay, thank you. Yeah, I don't remember off the top of my head about the UB04, so thank you for that clarification. Okay. And then the last question that I can see is dietitians can have an MPI number for billing. Nurses do not. Do not confuse Medicare rules with Medicaid rules. Did we answer that one? I think so. Yeah, today's discussion is entirely focused on Indiana Medicaid. And note that any state Medicaid program is a state Medicaid program. They differ state to state, and Medicare rules are different than Medicaid rules.
Yeah. Yes. And I think part of it too was also for me clarifying that initially I was referring to Medicare rules where Medicare, for a typical dietitian, it's an RD that's listed as a provider, a recognized provider, whereas Indiana Medicaid actually recognizes nurses, pharmacists, and dietitians. And I think what in our technical assistance and discussions with different hospitals around reimbursement, there's some more related to the actual referral, the document that is used to submit a reimbursement, a request for reimbursement. And again, I would say that, you know, I've noted here in the chat box, Marjorie has again listed that for those of you who have additional questions, or you're interested in receiving any kind of technical assistance from ISDH in your telehealth journey, the website that you can send those questions or let us know if you're interested in receiving technical assistance is Diabetes Heart. Again, no dot, just Diabetes Heart at isdh.in.gov. And so just seeing if we've covered everything else that's been in the question box. Marjorie, do you think we've covered it all? You're looking at it as well?
Right, I do not see any open questions.
Okay, so we thank everyone who has joined this webinar, and please feel free to, like I said, reach out to us and let us know, you know, we may be, you know, we've attempted to cover the basics. We may not have addressed your particular concerns, your particular questions, but please don't give up on us. If you have questions that we haven't addressed, please forward them to us and we will do our best to answer them for you.
Thank you.